And welcome to the TSIR annual meeting, and it's my pleasure to be introduced by my mentor teacher, Professor Huang. And today it's the last topic about DC drug-eluting beads. So I will give some information. I hope it doesn't mix together and get bored of you. But I am going to share the optimizing the taste outcome in HCC, clinical experience in using the DC bead and the True Select microsphere. And how to optimizing the taste outcomes in HCC, I have categorized into 5 parts. The treatment goal, we have to think that are we going to cure the disease by including the downstaging, or are we going to do the disease control, or even just palliative treatment? So, and also the second part is the patient selection about the HCC staging and the liver function, ECOG performance, and is there any comorbidities? And most of the important is the tumor size and the tumor number, vascular invasion, and the location. And the fourth part is our technique, how to choose the embolic size, how to use the dose, and even how to super select or lobar select to treat the HCC. And also, are you going to do the sequential treatment of adaptase, or maybe we can combine with systemic therapy? So that's the first part of the treatment goal. The HCC nowadays has updated that in ESO guideline that when patient comes to us, now we have a HCC patient. We don't think about stage A, B, C, D. Now we are thinking about can we cure the patient, or we are going to do the disease control no matter at what stage. So for tumor ablation, that means that we are going to cure the disease. So adaptase will play a role in downstaging for operation. So this is a case of adaptase, 77-year-old female with HCC around 6 centimeters. Actually, it's a quite good candidate for adaptase treatment. So we give a vial of 100 to 300 drug-eluting beads loaded with 70 milligrams of epirubicin. Then you can see that the images at the beginning is the hypervascular of the tumor, and then the follow-up 2 months later, almost total necrosis of the tumor. So the patient had the chance to get operation. And also the pathology shows marked tumor infarct and the foreign body thrombi. Then move on to disease control, because most of the time we do adaptase because of the multiple HCC without vessel invasion. For this kind of situation, we do adaptase for palliation or prevention of disease progression. And also preserving the liver function, get the patient had the chance to repeat radioembolization, chemoembolization, or to combine with systemic therapy. So, adaptase case 1, 51-year-old male with HCC, multiple HCC located in both lobes of the liver. You can see the hypervascular tumor under angiography, and then we've done the first adaptase. We used 2 vials of drug-eluting beads. Then for the second time of adaptase, you can see actually marked necrosis of the tumor already, but still some faint hypertumor stain. Then after several times of adaptase and including using Lipiodol, you can see the upper part is the hypervascular tumor before treatment, but the lower part you can see the necrotic of the tumor. And when we added Lipiodol, you can see the Lipiodol retention. But this is a good case for adaptase treatments. And then move on to the patient selection, tumor size, and technique. Then I have to say, we have our own consensus about HCC recommendation for adaptase. So why we have our own consensus? Because at the beginning, Lencioni has their recommendation for adaptase, but because we know that HCC are different in Western country and Eastern country, including how we treat the HCC and including we have larger HCC. So we have our own consensus. We have the patients, we mentioned the patient selections. We can do adaptase similar as CTase. even extended the patient to portal vein tumor thrombosis, VP1 or VP2. And sometimes we do it for palliative treatment because we are going to decrease the side effect. And also, most of the time, I think we have larger tumor. So we usually have extreme hypervascular tumor. Then at that time, we try to add some embolic agent, even like unloaded beads or gel foam. And about how many times we can do for DAPTase. Actually, there's no maximum number of embolization if the patient can be tolerated, and we can target the tumor as we want. And I want to compare, because we talk a lot about why DAPTase or CTase. So I want to talk about, should we choose DAPTase or CTase? DAPTase versus CTase. Actually, current evidence shows no significant difference that DAPTase is superior than CTase in terms of safety and efficacy. But why we still do DAPTase? Because it eliminates the toxicity associated with systemic therapy, systemic chemotherapy. Why? Actually, it's decreased the side effect. The patient will tolerate it more. So is DAPTase more effective than CTase? Actually, there are two different groups that sometimes patients, the article tells us that DAPTase is better than CTase. Then you can see the size is bigger, up to 6.7 centimeters. But if the article tells you that almost the same effect, actually I have seen that almost the same size, like 3 centimeters. But I have to say, if the tumor is 3 centimeters, I would do CTase also. So size doesn't matter. DAPTase might be more efficient in larger tumor, maybe larger than 5 centimeters, and it can reduce the liver damage and less side effect by doing DAPTase. And also, Korean has updated their liver cancer treatment too. And why they have also mentioned why they choose DAPTase treatment. For selection of embolic agent, actually, hepatologists, the clinician, will choose DAPTase due to mild post-embolization syndrome. But the IR doctors, we choose to do DAPTase most of the time depends on the tumor size. And DAPTase versus CTase, actually, it's like similar survival outcomes for the Korean recommendation, but the DAPTase had advantage in milder post-embolization syndrome, shorter hospitalization, and beneficial for patients with poor performance status or even old age. And the disadvantage of DAPTase is that if the tumor is too small, please choose CTase. And also, this is the Taiwan articles that we have. Taiwan multi-center included 30 patients underwent DAPTase. And most of the patients are within LB score 2. And we do the subsegmental treatment. And the DCB size is around 100 to 500. So the objective response rate is around 64%. CR rate is around 15%. But you can see that there is no change of the bilirubin and also the liver function. The median overall survival is around 29 months. And this is, I stole from Dr. Liu, advanced stage SCC with portal vein tumor thrombosis, that we can do DAPTase, but we have to choose smaller particles maybe within 100 micrometer to get deep penetration to the portal vein tumor thrombosis. And the pathology shows that the DAPTase microspheres can penetrate into the portal vein tumor thrombosis. Then, I would like to mention the technique, because when we do the DAPTase, actually we have to do super selection. So this is a good candidate because like we can see the hypervascular part, but we have to super select to each blood vessel, feeder vessels. So I choose the True Select microcatheter. Okay. move on to the combination treatment because it's the hot topic now, because we have to find our role. So we try to combine local regional therapy with systemic therapy. So the disease control for adaptase combined with systemic therapy. Why? Because adaptase can deliver chemo to tumor arteries, but systemic therapy can target the micrometastasis, systemic burden, and combine these two therapies can enhance the efficacy, prevent progression, and downstaging the tumor. So TACE will get the tumor necrosis, and it might be immune-promising also. And systemic therapy blocks the angiogenesis or activates the immunity. So combine these two treatments, local regional treatment with systemic treatment might have an anti-tumor action. So actually, Dr. Liu has already tell us about the articles. So you can see there are several articles that published for adaptase with systemic therapies. So you can see that it's quite promising to improve the progression-free survival, to have higher objective response rate. So in my institution, we have our own study that for sorafenib combined with TACE for intermediate HCC. And we have, for combined treatment, it's statistical significant in time to progression time. And also for advanced HCC, actually for both time to progression time and overall survivals, combined therapies has the better outcome. This is the case for adaptase combined with target therapy. A 12 centimeter HCC. We can see the hypervascular tumor stance, so we do the adaptase and also we have done the CTACE. But why we combine with systemic therapy? Because of the lung metastasis. So after the combined treatment, you can see the lung metastatic tumor decrease, but we still have a good necrosis of the liver cancer. Another case of combined treatments, that this case that done adaptase for 3 times and combined with systemic therapy. You can see good necrosis of the tumor. Another encouraging case is this one. HCC located in segment 1 with 8 centimeters. Actually, for this kind of case, I don't think it will have good outcome. But after 5 times of adaptase combined with systemic therapy, you can see the follow-up images, almost 3 years. They have the complete response and even shrinkage of the tumor. In conclusion, adaptase plays a role in downstaging the tumor. It can convert unresectable tumor to resectable. And also, most of the time, we do adaptase for disease control. We repeat adaptase and combine systemic agent to help maintain liver function and prolong survival. And combine 2 treatments shows superior outcome in intermediate and advanced HCC. Maybe using immunotherapies with interventional therapies will boost the immunogenicity. Thank you.